Good afternoon. Today we're going to talk about COPD, which is the exemplar of our gas exchange concept. This slide kind of shows you the pathophysiology of COPD. Noxious particles and gases, such as tobacco smoke, are what enter the system, and they kind of launch an inflammation in the central airways. The peripheral airway starts doing some remodeling. There's some imbalance between proteinase and antiproteinase. And then there's some pulmonary vascular changes. The vessels become thick. There's some inflammation in the cells infiltrate, collagen deposits, and destruction of the capillary bed. And this is what then is the pathophysiology of COPD. So to continue that on the COPD pathophysiology, some defining features are airflow limitation is not fully reversible during forced exhalation due to a loss of elastic recoil and airflow obstruction from mucus hypersecretions, mucosal edema, and bronchospasms. The main characteristic of COPD is the inability to expire air. The main site of the airflow limitation is in the smaller airways. As the peripheral airways become obstructed and trap air during expiration, results in increased residual volume, which results in a barrel-shaped chest, like you'll sometimes see with patients with COPD. This causes function residual capacity to increase. The residual air combined with the loss of elastic recoil make passive expiration of air difficult. The patient must now inhale when the lungs are in an overinflated state. As a result, the patient becomes short of breath with limited exercise capacity. Gas exchange problems result in hypoxemia and hypercapnia, which is an increase of the CO2. As the disease worsens, the air trapping increases, walls of the alveoli are destroyed. The villi, large air spaces in the perineum and bleeps, can form in and on the lungs. This causes the gas exchange to be difficult and it's ineffective and does not contain a capillary that normally surrounds each alveoli. Therefore, a significant ventilation perfusion VQ mismatch results in hypoxemia and hypercapnia. They have excessive mucus production and cough are features of persons with predominant chronic bronchitis. However, not all COPD patients have sputum production. When present, excess mucus production results from an increased number of mucus-secreting goblet cells in large submucosal glands, cilia dysfunction, and stimulation from inflammatory mediators. Pulmonary vascular changes causing mild to moderate pulmonary hypertension may occur in the late course of COPD. The small pulmonary arteries vasoconstrict due to the hypoxia. As the disease advances, the structure of the pulmonary arteries changes, resulting in thickening of the vascular smooth muscle. Because of the loss of alveoli walls and the capillaries surrounding them, pressure in the pulmonary circulation increases. Pulmonary hypertension may progress and lead to hypertrophy of the right ventricle. The right ventricle dilates and may lead to right-sided heart failure. This slide just kind of gives you an idea of what a normal set of lungs looks like and in contrasting it to a patient with COPD. Previous definitions of COPD have included such terms as chronic bronchitis and emphysema. Each condition has features of COPD, but neither by itself is COPD. Chronic bronchitis is the presence of cough and sputum production for at least 3 months in each of 2 consecutive years. It is an independent disease that may precede or follow the development of airway limitation. Emphysema, the destruction of alveoli without fibrosis, describes one of the several structural abnormalities in COPD. Around 16 million adults in the US have COPD. The number of people with COPD is underestimated because the disease is usually not diagnosed until it is moderately advanced. COPD is the third leading cause of death in the US, causing more than 140,000 deaths each year. As far as gender, male versus female, men with COPD is slightly more common and they have a poor response to oxygen therapy. The prevalence of COPD is increasing in women and more than likely due to more women smoking, and they have smaller lungs and airways. Women who smoke are 50% more likely to develop COPD compared to men. And women have a lower quality of life, more exacerbations, less phlegm, and increased dyspnea. So what are some of the COPD risk factors? Obviously, we all know that cigarette smoking is one of the major risks for developing COPD. Infections, so like severe recurrent respiratory infections in childhood are associated with reduced lung function and increased respiratory symptoms in adulthood. TB is also a risk factor for COPD. People with asthma, there is a considerable pathologic and functional overlap between COPD and asthma. And people who live in high air pollutions, like places where the air quality is not very good. The effects of outdoor air pollution is a risk factor for developing COPD. And if you have somebody that has, maybe for instance, they worked in a coal mine or something like that, or any other type of biomass fuels, it also increases the risks. Occupational chemicals and dust, intense exposure to various dust, vapors, irritants, or fumes. Aging, normal aging results in stiffening of the chest wall and decrease in exercise tolerance. The lungs gradually lose their elastic recoil and their thoracic cage becomes kind of rigid and their ribs are less mobile. The shape of the rib cage gradually changes because of the increased residual volume, causing it to enlarge and become more rounded. This is that barrel chest. Decreased chest compliance and loss of elastic recoil together affect the mechanical aspects of ventilation and increase the work of breathing. AATD is a protein made by the liver, and it's found in AAT is a protein made by the liver and normally found in the lungs. The main function of AAT is to protect lung tissue from proteinase during inflammation related to smoking and infections. About 2% of all people diagnosed with COPD in the US have undetected AATD. There are quite a few of the clinical manifestations. It is in your book as well. There's a full list. But it is distinguishable from asthma. They can have chest heaviness, can't take a deep breath, gasping. They have an increased effort to breathe. They could use their accessory muscles in which to breathe, and they feel like an air hunger, like they're starving for air. The shortness of breath is usually what brings patients into the hospital because they're not able to breathe or catch their breath, and they'll end up coming into the hospital because of it. Wheezing and chest congestion, decreased breath sounds. They can have wheezing. You can hear that with or without auscultation. They might have a prolonged expiratory phase. They'll have weight loss and anorexia because of how it just takes a lot of effort to eat, and many of them just get tired and they're full and they don't want to eat. So we will see a nutritional deficit in these patients. They have the fatigue. You can see them sitting in that tripod position. You could also see them doing pursed lip breathing. and peripheral edema, mostly in the ankles, which is a side of right-sided heart failure. And then they could have some cyanosis. They could have that bluish tint, um, like a bluish red color on their skin. So you can see, like, even in their mucous membranes, that they might be discolored. So these would be clinical manifestations that you could potentially see with patients with COPD. Some complications that result from COPD. The primary complications include pulmonary hypertension, cor pulmonale, and acute exacerbations. In COPD, the main cause of pulmonary hypertension is constriction of the pulmonary vessels from alveoli hypoxia. Chronic hypoxia stimulates red blood cell production, which cause polycythemia. This results in increased viscosity of the blood. These patients have increased pulmonary vascular resistance and as a result develop pulmonary hypertension. Cor pulmonale results from pulmonary hypertension. It is a late manifestation of COPD. It is a type of right-sided heart failure caused by a respiratory system disorder that leads to pulmonary hypertension. This condition causes the right ventricle of the heart to enlarge and weaken, forcing it to pump harder to move blood through narrowed or blocked lung arteries. Acute exacerbations of COPD is an acute event characterized by worsening of the respiratory system. Exacerbations are signaled by a sudden change in a patient's usually shortness of breath, cough, and or sputum. So some diagnostic tests, of course, you're going to do a history and a physical assessment. We can do spirometry. It confirms the diagnosis in those suspected of having COPD. It confirms the presence of airflow obstruction and determines the severity. Serum A1 antitrypsin levels measure the AAT protein in the blood. We talked about the 6-minute walk test yesterday in class. And it is the values of the O2 saturation are 88% or lower when at rest and the patient is breathing room air. They qualify for O2 therapy. ABGs, we already discussed those previously. An ECG may be normal or show signs of right-sided heart failure. Echocardiogram or an MUGA scan can evaluate the heart function. And then, of course, we have the sputum culture and sensitivity, which could let us know if there's an infection such as pneumonia. So you can see there's many different medications for the drug therapy. Bronchodilators, they help relax smooth muscle in the airway. They improve ventilation of the lungs, decrease dyspnea, and increase FEV1, which is forced expiratory volume in 1 second. It is a measurement of how much air a person can exhale in the first second after inhaling. The inhaled route is preferred. The choice of bronchodilator depends on the patient's response. A short-acting beta-2 adrenergic agonist is a mainstay of COPD, and the most common you'll see is albuterol. LABAs are often used as monotherapy, and anticholinergics block the action of acetylcholine on the receptors in the smooth muscle of the bronchotracheal trees. Combining short-acting bronchodilators and anticholinergic medication into a one combination drug may help improve bronchodilation of the airways and potentially decrease the risk of side effects. ICS is not used in monotherapy in COPD because of its side effects. It is often combined with a LABA for an advanced effect. There's also some oral anti-inflammatory drugs that are used for long-term therapy. We can use NACs. They may help improve overall health and quality of life in some of the patients. They have an anti-inflammatory and mucolytic properties. Inhaled long-acting Anticholinergics, LABAs, ICSs help reduce the risk of the exacerbations. And then sometimes we have the triple therapy, the LABA, LAMA, and ICS. We see it all the time. There's new drugs and treatments that are becoming more and more available for patients because we can see that there are a lot of patients with COPD, and that doing something to help with the breathing and their quality of life is definitely something that a lot of research has been placed on. There are different surgical therapies. Various surgical procedures can help manage severe COPD. However, it's important to remember that many patients with severe COPD are not candidates for surgery. One type of surgery is lung volume reduction surgery. The goal of this is to reduce the size of the lungs by removing some of the diseased lung tissue so that the remaining healthy lung tissue can perform better. Bronchoscopic lung volume reduction. This involves placing multiple one-way valves by a bronchoscopy in the airways leading to the diseased parts of the lung. The valves allow air to leave the lung during exhalation and prevent air from entering during inspiration. Bulloctomy is one or more of the very large bullae are removed. It helps to decrease the work of breathing. Oxygen therapy is often part of the treatment of COPD. It's the only treatment linked to improved survival. For most patients, the goal of O2 therapy is to keep the SaO2 greater than 90% during rest, sleep, and exertion, or the PaO2 greater than 60. These goals may be modified for patients with moderate to severe COPD. For example, based upon the patient's condition, the healthcare provider may accept an SaO2 or PaO2 greater than 88%. Some complications of oxygen therapy, of course, we've talked about combustion, no smoking or open flames. You can have CO2 necrosis. CO2 no longer stimulates to breathe. Hypoxic drive, administer O2 carefully. With patients that have COPD, we are really careful at what we do as far as giving them oxygen therapy, and oftentimes you'll find that the doctors want them to have a lower SpO2 because when you give increased amounts of oxygen, what occurs is that the body doesn't have to work so hard to breathe, and it becomes very dependent upon that oxygen. So trying to wean them off is very difficult because the body doesn't want to have to work so hard in which to breathe. It's often a considerable reason why in patients who have to have surgery, they don't like patients with COPD to end up ventilated for any particular reason or to be in surgery for a long period of time. Because what happens is if they end up ventilated, the body doesn't have to work so hard. That drive, that natural drive we have in which to breathe just is not as strong because it doesn't have to work so hard. So they just relax and the body says, this is so great. I don't have to work so hard. I'm not so tired from breathing. And so trying to wean them off, especially ventilation, is extremely important, is extremely difficult because they've become so dependent on that oxygen and the body does not want to have to work so hard. We can have O2 toxicity. So prolonged high O2 levels, they can get severe inflammation. You can get different infection because there's some bacterial growth. So we can use the humidifiers that we talked about yesterday. And so we can use that sterile water to help lubricate and help the patients. So these are some of the different complications. Teaching the patient with COPD breathing retraining exercises is very important. The two main types of breathing retraining exercises are pursed lip breathing and diaphragmatic breathing. Diaphragmatic breathing is, in some patients with COPD, may increase the work of breathing and dyspnea. So it's just a deep breathing. It helps. It's a relaxation technique that involves taking slow, deep breaths using the diaphragm and abdominal muscles. CPT, which is that chest physiotherapy, is a treatment that helps improve breathing by removing mucus from the lungs. Postural drainage is a technique that uses gravity to help drain mucus and other secretions from the lungs. Percussion, it's using cupped hands to hit the back in a steady rhythmic pattern over the areas of the lungs that have excess mucus. A vibration is a technique that gently shakes the mucus so it can move into larger airways. High frequency chest wall auscultation, a type of chest physical therapy that uses a machine and inflatable vest to help clear mucus from the airways. Many COPD patients with advanced disease are underweight with loss of muscle mass. Weight loss, malnutrition, and muscle dysfunction can affect quality of life and contribute to increased mortality. Factors that contribute to malnutrition include increased inflammatory mediators, increased metabolic rate from ventilation effort, and lack of appetite. Other factors include taste changes caused by chronic mouth breathing, excess sputum, fatigue, anxiety, depression, and drug side effects. There's no specific diet for the patient with COPD. The consensus is that a well-balanced diet that includes fresh fruits, whole grains, and vegetables is best. A diet high in protein, moderate in carbohydrates, and moderate to high in fat is recommended for most patients. Meals can be divided into 5 or 6 small portions, and that's generally what is much easier for the patient to do, is to eat smaller meals. They take in the nutrients instead of trying to eat 3 large meals. It's too much effort. They get tired. They won't eat. Some other things that we can do is to also encourage them to have like Boost. Those additional protein drinks help to increase the protein that they have. Offer high protein and moderate calorie nutritional supplements, which is what I was just talking about, like the Boost. Underweight patients need more protein and calories. They may need 25 to 45 kcal kilograms body weight and more than 1.5 grams of protein to maintain their weight. To decrease dyspnea and conserve energy, the patient should rest for at least 30 minutes before eating and use a bronchodilator before meals. Teach the patient to avoid exercise and treatments for at least 1 hour before and after eating. If a patient starts to, their O2 saturation starts to desaturate while they're eating, O2 by nasal cannula may be helpful. That's the easiest way. They can still eat. There's nothing that's blocking the face. So in your assessment, you want to look at subjective data, functional health patterns, and objective data. Important health information, long-term exposure to chemical pollutants would be something I'd ask. Any occupational dusts or fumes, any type of medications that they're using, the use of oxygen, over-the-counter medications, and corticosteroids. Functional, I talk to them about elimination, their rest and sleep patterns. Smoking, are they currently smoking? Did they smoke in the past? How long ago did they quit? How many years did they smoke? Weight loss or gain, shortness of breath, wheezing, constipation or bloating, stress, anxiety, and depression. Objective, you're going to look at just a general. Are they restless? What's their position look like? Are they sitting in a tripod position? Do they look like they're working hard to breathe? In the GI areas, do they have any ascites? Look for a barrel chest, muscle atrophy. Respirations, rapid, shallow breathing. Like I had said, the use of accessory muscles, any wheezing. Cyanosis, poor skin turgor, peripheral edema, And then look at the diagnostic findings, the ABGs, the pulmonary function tests, and the chest x-ray to evaluate. So some nursing diagnoses that would be relevant for the COPD patient include impaired breathing, activity intolerance, impaired nutritional status, difficulty coping, the changes of life, not being able to do the things that they used to do. Maybe they're on oxygen therapy and now they feel like they're more confined to their home environment. Some goals would be some relief from the symptoms, ability to perform their ADLs on their own, and improved exercise tolerance. With these patients, when you're doing an assessment, when they're at advanced stages, you might have to actually break your assessment up into two parts, meaning that you do one section and then give the patient time to rest and then come back and do then further your assessment, because they just get exhausted and oftentimes they'll get kind of irritable and tell you that they're done. They don't want to do anything more because they're just, it's a lot of energy that they're expelling doing that. Some other goals would be no complications, that we provide knowledge and they have the ability to implement a long-term treatment plan, like they can adhere to it, they understand it, prevention of the disease progression. And then overall, what we're looking for is a better quality of life. Like, how can they continue to do the things that they used to do? I know that for some, like I was talking about with the oxygen therapy, when they have those big tanks at home, they're not dragging those around. Fortunately, now they have a lot of these little portable devices that patients can use, and they can get out and move around and do things again, where they're not just sitting at home, because we know that that is not healthy for them as either, because then they're just kind of laying around, sitting around. But we want to improve that quality of life. Nursing implementation. So health promotion, the incident of COPD would decrease dramatically if people did not begin or start smoking. Counseling the patient and smoking cessation is vital. It is the only way to slow the progression of the disease. People with COPD should avoid others who are sick, practice good hand hygiene techniques, take their medications as prescribed, exercise to the point that they are able to regularly, and maintain a healthy weight. Early diagnosis and treatment of respiratory tract infections, the flu, and pneumonia vaccines would be like very high on the list. We want to make sure that they have them. Awareness of family history of COPD and AAT deficiency. There could be some genetic counseling with that. In the acute care, hospitalization is required when they have those acute exacerbations or complications. The degree and severity of the underlying respiratory problems should be assessed. On an outpatient basis, a large part of our role is to help the patient self-manage the disease. They really need to learn how to manage the disease instead of the disease managing them. Stress the importance of regular follow-up appointments. Regular follow-ups help to monitor response to treatment and see if any changes need to be made. Teach the patient and or their caregiver or family member early recognition of the three mainstay manifestations of exacerbations: increased shortness of breath or dyspnea, increased sputum volume, and increased sputum purulence. So if they've got some yellow sputum. Pulmonary rehab is designed to help reduce symptoms and improve quality of life. It includes an exercise training, smoking cessation, nutritional counseling, and education. There are also alternate internet programs available. And if the patient has a problem with, like they're trying to stop smoking and it can be very difficult for some patients, they do have a lot of free services available to try to help. And it's not just giving them patches, but it's also like support groups, counseling for them so that they can, work on stopping smoking. It's very hard. It's a habit. So people have a difficult time with it. Expected outcomes is that to maintain the patent airway by effectively coughing, teaching them how to spit that out, better out than in. Don't leave that sputum in their chest or in their throat. If they cough it up, get it out. Have an effective rate, rhythm, and depth of respirations. Have clear breath sounds and return to pre-exacerbation baseline respiratory functioning, and have PaCO2 and PaO2 values within normal for the patient. Remember, they may not be in normal range as we would see it, but you need to see what would be normal for your patient, that patient. I know we stress a lot on the older population, but here, they have some physiological changes, including reduced lean body mass, decreased respiratory muscle strength, increased dyspnea, and lower exercise tolerance that may increase the burden of the disease of COPD. This may lead to a higher incidence of acute exacerbations, which require hospitalization. Smoking cessation is a key intervention, but it may be hard to achieve. Older adults have difficulty handling increased secretions during an exacerbation because they already have a lot of them have problems swallowing. Their gag reflex is not what it used to be. COPD is often complicated by the presence of other problems such as diabetes, heart disease, hypertension, osteoporosis, impaired cognition, and lung cancer. These problems make it harder for patients to cope with the stress of an exacerbation. ACE inhibitors, often used for hypertension and heart failure, may cause a dry cough or worsen a present cough. So if a patient has those and they're taking an ACE inhibitor, that needs to be a conversation so that we could potentially see if a different hypertensive medication would work for them. Older patients with COPD often have impaired quality of life. An important role for us is to focus on ways to improve that quality of life. Psychological support becomes imperative to help patients achieve successful outcomes. In the later stages of COPD, palliative and hospice care can help manage symptoms and improve the quality of the rest of their lives.